Welcome to part 4 of musculoskeletal. This PowerPoint will focus on osteoarthritis and joint arthroplasty. Osteoarthritis is a non-inflammatory degenerative disorder of the joints. It's the most common form of joint disease, and it's sometimes called degenerative joint disease. Osteoarthritis does not have any systemic symptoms. It's limited to the affected joints. Osteoarthritis is very prevalent in adults over 40, even if there are no symptoms. In osteoarthritis, articular cartilage breaks down, leading to progressive damage to the underlying bone. Over time, that damaged bone will form osteophytes, or bone spurs, that protrude into the joint space. These osteophytes narrow the joint space and causes decreased joint movement and potentially more damage. Osteoarthritis often affects the weight-bearing joints like the hips, knees, cervical, and lumbar spine. The risk factors for osteoarthritis include older age, female gender, obesity, playing sports, hard labor occupations, history of previous joint injuries, muscle weakness, genetic predisposition, and certain diseases. The most prominent modifiable risk factor for osteoarthritis is obesity, and diet and exercise can help minimize symptoms in osteoarthritis in patients with obesity. The main symptoms of osteoarthritis are joint pain, joint stiffness, and functional impairment of the joint. Joint pain may be aggravated by movement and exercise and is usually relieved by rest. There may be morning stiffness during the first 30 minutes of movement during the day. Some people may have crepitus in their joints, especially the knees. The affected joint may be enlarged due to inflammation, and there may be decreased range of motion. The symptoms usually develop over multiple years. There are no blood tests to check for osteoarthritis, but x-rays can be used to show narrowing of the joints and osteophytes. Some surgeons may do a procedure called an arthroscopy, where they use a little camera to see inside the joint to evaluate the damage and possibly remove any small areas of joint damage. The plan of care and goals for osteoarthritis are to decrease pain and stiffness and regain range of motion and use. One treatment that is very effective but causes pain, so people don't want to do it, is exercise. Cardiovascular aerobic exercise and lower extremity strength training have been shown to decrease the symptoms. Weight loss, if the person is overweight or obese, helps relieve the pressure on the joints and can decrease progression of disease and symptoms. Occupational and physical therapy can help the person lose weight and learn self-care strategies to minimize their symptoms. People may need to use pharmacological treatments to help manage the pain. The initial analgesic treatment is acetaminophen or Tylenol. If this does not work, NSAIDs such as naproxen or Aleve. Opioid medications may be used in severe cases, and some providers will use intra-articular injections of corticosteroids to help with the symptoms. If the previously mentioned symptom management strategies don't work, the orthopedic surgeon may decide to do a joint arthroplasty or removal of unhealthy joint tissue and replace it with metal or synthetic materials. Some patients have such severe disease that they need a total joint replacement, where the entire joint is removed and replaced. Arthroplasty is used in people with severe osteoarthritis and also may be used for certain fractures like hip fractures. The joints most commonly replaced are hips and knees. Shoulders can be replaced as well, but not as frequently as hips and knees. People who undergo joint arthroplasty have less pain, increased joint movement, and better quality of life after the healing phase is complete. If they do have a hip fracture, surgery is usually done to reduce and fixate that fracture. And care for a patient who has a joint arthroplasty because of a hip fracture is going to be the exact same as a surgery for a joint arthroplasty if it wasn't fractured. For patients undergoing a total hip arthroplasty, the surgeon is going to prepare the patient beforehand and get them in the best shape for surgery. This may include diet and exercise, weight management, and comorbidity control like diabetes, heart disease, and smoking. The goal of the surgery is to relieve pain and have functional, stable hip joints. The risk and complications of the surgery may include bleeding, because the femur is a long bone that makes a lot of our blood cells. Blood clots, those VTEs, from decreased mobility after surgery, and infection from the incision site, and possible pneumonia from not being as mobile are the major complications. The patient may also develop pressure injuries, especially in the heels, from decreased mobility, and if the new joint is not cared for properly, the new hip prosthesis may dislocate out of its joint. To prevent dislocation of the new hip prosthesis, nurses need to make sure they're using the correct positioning as prescribed by the surgeon. This can include the use of a wedge pillow to prevent the legs from coming too close together, to prevent hip abduction while turning, and to prevent adduction while transferring. We also want to limit flexing of the hip more than 90 degrees. To prevent blood clots and pneumonia, we make these patients ambulate within the first day of surgery. Some patients are even going home the same day of surgery, so early ambulation is very important. In addition to ambulation, the surgeon may prescribe blood thinners like enoxaparin or Lovenox or heparin for several days after surgery. The surgeon will prescribe how much weight the patient can put on their new hip joint. If the patient has a drain at the incision site, we need to monitor the drainage for bleeding and infection. We'll also do prescribed incision care. There are a lot of really cool hip incision dressings out there, so we may not even need to change the dressing for several days. Getting these patients up and moving so fast has been shown to significantly reduce the complication, so most of these patients who do get admitted to the hospital after surgery will be discharged within 24 hours. In addition to all of this, we will assess our 5 Ps, manage pain with prescribed medications, and make sure that the patient's ambulating. Caring for a patient with a total knee arthroplasty is very similar to a total hip. They have the same risk and complications, and we manage their care almost exactly the same. The only difference is we do not need to use a wedge pillow to keep the legs apart. Total knees do not have the same risk of dislocation while turning or with crossing the legs. The knee is usually protected with a knee immobilizer, which keeps that joint stable and is going to prevent any dislocations. These patients ambulate even faster than hip arthroplasties, and the majority of these patients are not kept overnight unless there's some sort of comorbidity that needs extra monitoring or if there were any complications during the surgery. And this is the end of part 4.